everyone. This is the Shelbourne Knee Center podcast. This is Dr. Benner, and we're here tonight for episode 28, and we're going to be discussing another topic as kind of a counterpoint to last week's topic. As always, if you want to hit up our social media, we have Facebook and YouTube pages for the Shelbourne Knee Center podcast. We have Instagram and Twitter handles at the SKC podcast. If you'd like to email us a question or a comment, you can do that at the SKC podcast at gmail.com, and we'd love to hear from you. As always, if you can follow us and give us a like and a comment for people that come behind you that would like to check out the podcast, we'd appreciate that as well.
And before we get into tonight's topic, which will be on mechanical alignment for total knees, go back to episode 27 for last week. We had on Dr. Stephen Howell from California discussing kinematic alignment in total knees. So I do think this one's going to be a good counterpoint for that episode. So if you haven't gone back to last week's, go ahead and listen to last week's before this week talking about mechanical alignment.
Tonight, we have another great guest and another mentor of mine that has been a very influential person for me in learning how to do total knees. He's the vice president of the orthopedic service line at Northwell Health. He's the director of surgical services at Long Island Jewish Valley Stream Hospital. He was an attending at the Insall Scott Kelly Institute, where I did my fellowship, which is where I got to know him well. And he's now the fellowship director for the Adult Reconstruction Fellowship at Lenox Hill Hospital in New York City. He's also the past president of the prestigious Knee Society. So tonight's guest, Dr. Giles Scuderi. Dr. Scuderi, thank you for joining us. We really appreciate this.
Hi, Rodney. How you doing tonight? Looking forward to having a good discussion. I'm sure it'll be a lively one.
Absolutely. And, we heard from Dr. Howell last week, and as we were talking about before we got started here, is something that I'm sure you've talked to Steve with extensively in the past, and I think I've seen you on the podium having that discussion with him before, so we're looking forward to this as well. So, people talk about mechanical alignment in the same way they do with, ACL tunnel placement that always kind of makes me laugh, is that they talk about mechanical alignment as if it's old-fashioned, it's outdated, it's conventional versus anatomic, and for me, it's still the goal every case. It's what I learned from you and what I know you learned as well. So, take us back to your training. Who taught you mechanical alignment, and why has that always been your goal?
Rodney, it's always good, to go back where all this started, and with John Insall, if you think about it, I always like to talk about John and have everybody remember John Insall is one of the pioneers in one of the fathers of total knee arthroplasty. And John really was a proponent of the mechanical alignment, getting the implants in the proper position, restoring the alignment of the knee, and that was able to deal with the successful outcome of total knee arthroplasty. So it does go back to John. I mean, this has been around for 40, probably going on 45 years now. Mechanical alignment has really been the gold standard. And I'm really amazed how everyone looks at the mechanical alignment as possibly a mortal sin, and we need to move to more anatomic alignment. I'm sure Steve presented a very strong case for kinematic alignment, but I think mechanical alignment is the gold standard, well proven in our registry data.
So with you talking about being the gold standard, in a nutshell, what is the advantage of mechanical alignment for total knee arthroplasty?
Mechanical alignment is very beneficial because you're not cherry picking or lemon dropping your cases. I mean, you can handle all types of deformities, severe varus and valgus deformities, fixed deformities. It's really a clear understanding. And I always said that you need to understand the identity of the knee. And what do I mean by that? Every knee has its own soft tissue identity. Every knee has its own bony identity. And every knee is a little bit different. I mean, I think that's why some of the proponents of a more personalized approach, look at knees different. But I think that with the mechanical alignment, you can address all deformities. You have to be prepared to handle the soft tissues, especially with fixed coronal deformity, a fixed varus or a fixed valgus deformity. Don't be afraid to release some soft tissue to get the proper alignment. John Insall always said, "Thou shalt not varus," and now all of a sudden with kinematic alignment, we're looking at putting the knees in a little bit of varus alignment. I'm just concerned about the long-term durability. We haven't seen it yet, and I'd like to see what the long-term track record is going to be.
Yeah, I mean, that's something that I know I heard you talking about, each knee having its own soft tissue character or soft tissue, soft tissue footprint, I guess, that we have to work around. I did a case today. A guy had a 16-degree varus knee, a 16-degree flexion contracture, and after my normal cuts. I would, this moves into a little bit in robotics also, but I took about 9 millimeters from the distal femur. I only had 7 and 5 from my posterior sections. I always measure all my resections just like you do, and I still had, even with that fixed varus deformity, I did a good medial release to try to get that balanced, and it was still looser laterally than I was comfortable leaving that way. So I ended up switching to constraint, and with the PRK system, I even had to use a plus component despite taking really minimal posterior resections. I still had to use a plus component to get good flexion balancing. And I thought back to, if I had done this case with conventional instrumentation, there is no way in hell I would have made those same cuts. And I certainly, with kinematic alignment, would not have been able to get this knee balanced with symmetric resections from the distal and posterior femur. I think that experiences like that just make me wonder how people who do kinematic alignment would handle knees such as that, and whether or not they would deviate from it. So I think you kind of already answered this, but is there any case where you do deviate from mechanical alignment? I know some people talk about mechanical alignment. Well, it's a one size fits all thing for the knee, and they don't necessarily think that's good. But for me, I don't necessarily deviate from it, and I doubt you do either.
I really don't. Rodney, because I still follow the basic principles, that, I taught you, hopefully, and it sounds like you still follow most of the principles, that, we've discussed a while back. I do a bit of a hybrid technique, with measure resection, gap balancing. But in order to do that appropriately, you need to have the appropriate mechanical alignment. I need my tibia component at 90 degrees at that neutral coronal plane. And I think that's important because that's really the foundation, for the arthroplasty. In all honesty, if I go back and I look, and I still remember, some of my early days as a fellow with John Insel back in the, I hate to say this, the late 80s,
Don't want to say the number, but
yeah, I don't want to say the number. I'm just going to say late 80s. Is that, I looked at the x-rays, and, where we say we were mechanical alignment, it was like 1 to 2 degrees of varus in the tibia, and that's with conventional instrumentation, and I still think my eye is pretty good. I always like to compete with the robot and see, how accurate am I with my eye and my spacer and my drop rod compared to what, technology is now allowing us to do. But I really don't deviate. I really feel that I need to have a good, stable foundation. I want to get the right forces across the joint, try to decrease any of the mechanical stresses on the implant by having the appropriate mechanical alignment. I think what happens, with some of these, functional alignments, kinematic alignments, personalized alignments, again, as I said earlier, there's a lot of different names with different parameters within it. You're changing both the coronal and sagittal plane, and that joint line. The obliquity of the joint line that these guys are trying to accept concerns me, and I still don't know what the guardrails are, within these alignment techniques. And that's why I go back to mechanical alignment, and don't be afraid to handle the soft tissues. You need to do a release, you do a release.
Yeah, I mean, and I one of my hesitancies with kinematic alignment is, I hear them say about mechanical alignment that we're making assumptions that everybody wants to be at neutral mechanical alignment, and that they think that that's potentially something that they want to avoid, and they want to have a more personalized approach and to, quote, put the knee where it wants to be. And for me, I just struggled to know what they really mean by that. And when I hear Dr. Howell talk, and I asked him this question specifically, he discussed when they used to look at MRIs and CT scans before their total knees, that they kind of made, I think they made an assumption, I'm sure he'll correct me if I'm wrong, but of 2 millimeters of articular surface wear, and that he didn't think there was any bony wear that had to be accounted for. And to me, that makes the same kind of assumption that you and I are making when we take any knee that's at any alignment and we try to put femoral head over the middle of the knee, over the middle of the ankle. So, that's kind of how I feel. And I was interested to hear your thoughts on that as well. Are there assumptions that KA makes with that technique that you don't believe are ones that you want to make, and how those compare with assumptions that we make, putting everybody at the same alignment?
Yeah, I think the assumption that they make is there are no bony deformities, really associated with it. They're really, doing, very early arthritic knees. I mean, it's really hard to do a knee with a severe deformity and bone loss and kinematic alignment. When you and I both know that you get a fixed varus deformity of 15 degrees or more, you have a bony defect in the posterior medial tibia. And how do you deal with that? I mean, really, when I see, Steve's cases, in all honesty, Steve does a great job. He gets great results. He's published extensively on it. He probably has published about 80% of the literature on kinematic alignment. And he does get good results, but I really have never seen the severe deformities that we tackle in Steve's cases. The severe valgus deformity, there is bone loss, on these cases, and how do you manage that? And how do you determine the position of the tibial component? And how does that drive your femoral component? So I'm still a big believer of getting that mechanical alignment correct, and I really don't deviate. What's surprising is, surgeons sometimes just want to deal with the deformity by a little adjustment in the bone cut and accept that obliquity, on the joint line. But why are they so fearful of releasing a tight ligament? That's just as easy. We've had good clinical success, both for fixed varus and valgus deformities with soft tissue balancing, and the gap balancers are doing that. And that's been a standard technique for years. So, they may call us dinosaurs because we're still doing the same technique. But, listen, we're open-minded. I'm open-minded. I think that we need to look at, how can we improve patient outcomes? How can we improve patient satisfaction? I really don't think personally that, improvement of patient satisfaction with a couple of degrees more of varus in the tibia or a little bit more valgus in the femur and a little obliquity joint line is really going to change patient satisfaction. There are other variables, to patient satisfaction.
Well, I'm glad you brought that up, and I have to confess that I don't remember the specific study. I know we reviewed it at one of our research meetings, and Jim Ballard, when we had him on talking about robotics, referenced a study in which they looked at their results based on whether or not people had soft tissue releases, and the people that did not have soft tissue releases had better outcome scores. And I don't doubt that if we put somebody's knee in a way that maintained their alignment and didn't release their soft tissues versus doing a large correction and releasing those soft tissues, I don't doubt that it probably would feel better temporarily. I mean, that's more of a long-term problem, I would think, as well. I mean, and I wish I had that reference. I could remember where that was, but I think that's some interesting data that we need in the future is what are the guardrails around that? If I throw it up on my, I'm using robotics. I don't know if you are or not, but when I throw one up that's got, 20 on one side and 18.5 on the other side, where if I could tilt that into a degree or two of varus, maybe all of a sudden those become equal without having to do any soft tissue balancing. I saw that when I went and did an observation, and I thought, that's something I hadn't really thought about doing. But I'm with you. A degree or two of varus in order to not have to do a release, I don't think it's a bad idea. I just think that's something that the literature needs to give us some guardrails and some concrete results on what to use and what not to.
Yeah, I mean, I agree. And I mean, I truly believe that looking at these more personalized approaches is something that, will be ongoing. I'm very supportive of it. I'm supportive of, research to determine the ideal parameters, for that more personalized approach. And that's what I like to call it more than, kinematic alignment, inverse kinematic, restricted kinematic. I mean, there's so many different names. It's almost like the Tower of Babel a little bit, with all the names. But realistically, what they're trying to do is, address the knee with a more personalized approach for both bone resection and soft tissue balance, and looking at the pre-arthritic alignment of the knee to try to restore the ideal environment, for the implant. And I think with the advent of, more modern components, more shapes and sizes to better fit the anatomy and, more advanced technologies, this debate's going to continue. And I think this personalized approach to knee arthroplasty is going to continue to gain more traction. But to your point, too, is we really need to know what the ideal parameters are, because if you look at most of the literature, the parameters are very different, and we're not comparing apples to apples.
Yeah. And here's my soapbox about alignment that I alluded to that I wanted to save to ask you in the podcast. When we look at the data on how much does alignment matter, we look at Merrill Ritter's data and the group out of Mooresville from our area that said that alignment outliers had worse outcomes, higher failure rates, and we look at Mark Pagnano and the Mayo Group's data with a pretty large internal registry for them that showed that their outliers did not have a difference in survivorship. So it doesn't seem like we can even figure out exactly how much alignment really matters in the long term. And then we have people like you and I who like our parallel and perpendicular ways of mechanical alignment, and Steve Howell and other people who do kinematic alignment who think a different target is the right thing to do. So one of my frustrations is we can't decide how much we think alignment really matters. We can't decide what our target is. What we can do as surgeons then is look at any post-op x-ray, we put the knee in any alignment we want and say, somebody probably thinks that's a good idea. I put this knee in 4 degrees of varus. The kinematic alignment surgeons think that's good. I put this one in, a little too much this way. Well, so this person says that might actually be a good thing. So I feel like it's a little frustrating to me, and I think we do this as surgeons a lot, where we try to come up with as many ideas as we can with the hopes that then we'll be able to support anything. And I just look at research a little bit differently. That let's put all these things to the test from a research perspective and really let the results guide us. And I'm with you. If there are studies that come out that start to get into the finer details of this, and there emerges to some reproducible advantages with kinematic alignment versus mechanical, I'm all for it. But for now, it just seems like there are so many ups and downs and sideways and forwards and backwards that it's kind of tough to make headway on and come up with the best plan.
I think you have to look at it in this manner. One is we have to look at the long-term durability of the implant. We know that in our survivorship data, and if you even look at the joint registry data, we reported on the 20-year survivorship of posterior stabilized, design with John Insel, the IB2, and, durability of that implant, 20 years, 90%, 30 years, anywhere between 65 and 80%. Mm-hmm. I mean, that's pretty good, long-term durability. So we want to look at the joint registry data, and see. And most of the registry data with longer-term follow-up is mechanical alignment. Right, because the kinematic alignment, the personalized alignment techniques are more recent techniques and more recent data that's being entered. So we don't have the long-term data. So one is durability of the implant. And then two, as I mentioned earlier, it's patient satisfaction. Are we making these patients happier? Yes, you can allude to the fact maybe a little less soft tissue release, but I'll be honest with you, I'm doing a lot less soft tissue releases than I did before. I think I have better implant shapes and sizes, so I get a better fit. And we have to realize that, patient satisfaction is really meeting expectations. Can they get back to doing things that they want to do? When we designed the Knee Society score, the more recent modern score, a little over a decade ago, we looked specifically at common activities of daily living, more advanced activities, and then patient-specific activities, because patients want to do things that are a little bit different than others that may put a little bit more demand. And we felt that was an important consideration to take into when you're looking, at outcomes. And there are also other socioeconomic variables that, come into play. What about, the patient's coping abilities? What about their anxiety, the patient, and that quote unquote 20% dissatisfied patient. I published this study recently, earlier this year, it's in JOA, looking at the fact that if you look at the literature with the current studies only about 10% of the patients are really dissatisfied. You take out the complications and you take out a lot of the variables and just look at the patients, that are unhappy with their knee. And it's not that 20%.
Yeah, I'm with you. I'm with you on that. I think, I think what's all pretty clear that if somebody has an infection, they're not going to be as happy with the outcome of their operation. Right. If they fall and they have a periprosthetic fracture, they're not going to be as happy as they could be with the outcome of their operation. But I think what all of us are worried about is that X-ray that looks good and feels bad. I think that's what everybody's trying to get after. And I agree with you. I think that number of dissatisfaction with an X-ray and a physical exam and infectious workup, et cetera, that all looks pretty normal, and they're just not happy. I have a lot of thoughts on that as well, but I don't know if that's probably outside the scope of this talk. Or this discussion, but I'm with you on that. I don't know that number's actually that exceedingly high. You mentioned soft tissue releases, and I was wondering about that myself. I'm glad you brought that up. When I worked with you, it was just at the very beginning of Persona. We just put a few of those in right at the end of my fellowship, and I know in my own experience, I started out with LPS Flex for a couple of years after I was in practice before I jumped in on Persona, and I wondered, with a change in a more modern system with a wider array of combinations that we can utilize, whether that has changed your ligament releases more than or in addition to all these thoughts about kinematic alignment.
Yeah, so one thing that has come up, since as you brought up Persona, I always like to try to keep things generic, but because obviously I'm biased, being one of the designers of the implant, but we've got some recent publications looking at restoring the anatomy of the femur. Historically, we've always been anterior referencing or posterior referencing. I'm trying, and I've coined the term anatomic referencing at this point, because I think that with the 2 millimeter increments in sizing, and there are a couple other, devices out there, femoral components from other companies too, besides the Zimmer Biomet Persona, that have closer incremental sizes. But with Persona, with the 2 millimeter increments, I can restore the anatomy of that distal femur, and I both have the standard and narrow components. And that addresses the femoral component flush to the anterior cortex. So I'm restoring the anterior compartment. I don't think we've really paid enough attention to the anterior compartment of the knee, the patellofemoral joint, as well as restore the posterior condylar offset. So if I pick the right shape and the right size and I restore the femur, I think that I have a better balanced knee. And I'm finding that my outcomes have been better, with that concept of anatomic referencing. So I have no compromise in the position of my femoral component.
Now, Dr. Scuderi, I've heard Dr. Benner talk about this frequently, and more so when we were talking about kinematic alignment last week. The worry is that there's going to be varus collapse with KA in the long term. Is there any literature that you're aware of that supports kinematic alignment in the long term, or have we really even followed it long enough to determine that?
So I don't think we followed it long enough. Steve Howell has presented some of his longer-term data, I think now at about 10 years. I'm sure Steve talked about that. But what I'm just concerned about is, drifting off of that 3 degrees of varus. How much varus would you accept in the tibia? Because we know that when implants fail, they do fail into varus. The bone gets weaker, they start to collapse. And that becomes a major problem. So I don't want to put myself in that position early on by putting the knee into a few degrees of varus. And it gets back to what we mentioned earlier about what's the ideal parameters and, what are the guardrails and how far we go out. It's always interesting. And I told this to Steve at one point. We were debating each other at one of the meetings. If you think about when the knee fails into varus and you go to do a revision, what alignment do you choose? The alignment you choose is to restore the mechanical axis. So why didn't you start there in the first place? Because the revision systems are designed, with stem extensions to support the bone, and that's to restore it into the mechanical axis. So, varus subsidence is probably one of the most common failure mechanisms of the tibial component.
Yeah, and that's something we did ask Steve about, and as I'm sure you've heard him talk about, it's his position that he thinks varus collapse is caused by not taking care of, not avoided by mechanical alignment, especially because on the femoral side that we've taken the knee out of a little bit of normal femoral valgus, and by putting it back at 5 degrees or 6 degrees or whatever one you want to put it at, that will get in line with the middle of the femoral head and the middle of the distal femur, that puts the knee in relative varus and causes medial collapse. Now, one thing I have heard him talk about, and I know he had a study that talked about this, was increases in the posterior contact pressures leading to like some cantilever forces on tibial components and causing some posterior tibial collapse. To me, that's a potential problem. I don't like when I see knees collapse posteriorly when I'm going to do revisions, because it's not a good way to augment that. As you know, you either have to get it up off bone and just fill it with cement, or you don't really have femoral resections that you can put back there and screw to the back of the tibia to augment that. Or you have to cut all the way down and potentially take several millimeters of anterior bone in order to flatten things out and end up with a pretty large insert as a result. So I don't like varus collapse either, but I don't like posterior collapse, and I definitely don't want that to be the next way that we see tibial components fail with KA and that we end up doing revisions on.
Yeah, you know what, though, Ronnie, I think it's also dependent upon your implant choice, though, too. So realize, I'm a posterior stabilized surgeon, and I have a very, conforming or articular surface. So, I'm distributing those forces, across that joint, in contrast to a CR, surgeon. Possibly, MCs and UCs are right in the middle there, and they may be a little bit more accommodating to a few degrees of varus in the tibia and valgus in the femur. Listen, I'm not saying that he's absolutely wrong. I just don't think it's the right approach that I've taken. I just haven't seen enough durability of these implants over time. But I think the implant choice is going to be one of the factors that come into play.
So before we started recording tonight, I mentioned that I spent early parts of my career as a physical therapist, and I've seen countless post-op total knees here, and obviously they're all Rodney's patients with mechanical alignment. But I wanted to get your thoughts on the rehab process post-operatively in terms of mechanical alignment versus kinematic alignment, and do you see any pros or cons either way, especially when you get into those patients like Rodney was talking about that he operated on this morning, somebody that does have 16-degree varus and 16-degree flexion contracture. So I just want your thoughts on what you're seeing post-operatively from a rehab standpoint, and if there's any advantage one way or the other.
When you consider alignment and rehab protocols, we're in a rapid recovery program. We do same-day surgery, short stay. Most of our patients go home either late that afternoon, or the majority go home by the morning. And we have them up and ambulating right after surgery within a couple of hours. So I really haven't seen any, difference. We've got a very structured program for our patients to get their motion, get their strength up, and it's early mobility. I can't tell you that my recovery program with mechanical alignment is any better than Steve's with, his kinematic alignment. I think it really is dependent upon good surgical technique, a well-balanced knee. We talk about alignment, but at the end of the day, what you want is a well-balanced knee that's stable, where you've restored the patient's range of motion. Okay, and I think that is truly what our outcome is in the short term, and what our long-term outcome is: durability of the implant, restoration of function early, durability of the implant to achieve, patient satisfaction. The recovery programs, we're all advancing our patients quickly. It's not like years ago where, we've had them on bed rest. The rapid recovery programs, the physical therapy programs are much more accelerated. And with same-day surgery, we're getting them up and out right away. We've improved our pain management. We've improved our patient optimization. So we're able to move these patients quicker. And I can't tout one over the other, and I would hope that I hope Steve hasn't touted, kinematic alignment over mechanical alignment for a more rapid recovery. I think just a well-done knee, should have, a good outcome. I'm laughing because I've been around long enough that back when I was a fellow in my early years, we were debating CR versus PS knees, and which one was better. I remember the battles between New York and Boston and New York and Chicago. And now at the end of the day, the market is still split 50-50, maybe shifting a little bit more to the MC at the expense of PS. But that battle of implants has pretty much died down. And now all of a sudden, we're having this, debate on, kinematic personal alignment versus mechanical alignment. I would venture to say at the end of the day, we're going to come back and say it doesn't matter as long as you have a well-balanced knee that's stable and has a good functional range of motion, achieving, patient satisfaction. I think truly that is where we're going to go. What's driving this too is technology, because we can, with robotics and computer navigation, even our handheld accelerometers, we can make little subtle adjustments in the alignment, and we can say this knee we've just put back, to in constitutional varus. If we go back and think about those studies, technology is allowing us to do some of this, and that's why we're having this debate. But again, I think this is going to be ongoing for a while until we have long-term outcomes that would show one that would be superior over the other. And my guess is at the end of the day, it's going to be the same, and it's going to be an outcome very similar to the PS CR debate, that we had in the 90s.
Yeah, honestly, that's another one that something I'm going to probably text you about in the future when I want to tackle that question on here, whether people that are doing medial congruent total knees versus still doing CR knees or doing PS knees like you and I do. And definitely a conversation for another day. And maybe this next question is too, but I asked it to Steve, so I'll ask you as well. Well, my feeling is one of the biggest reasons that I see people come in to see me for another opinion on a bad total knee that was done elsewhere that is not functioning well and is still painful is component rotation. I revise a lot of knees for pretty significant component malrotation, and to me, that's one of the really missed alignment parameters that are leading to a lot of these patients that have good-looking X-rays from a coronal and sagittal alignment, but they're still unhappy. And I've had really good results with revising those people if we can't get them better with non-surgical treatment, and after changing their rotation, especially on the tibial side, pretty significantly, that they achieve really good results. So how do you reconcile component rotation in amongst all this talk about coronal alignment with K versus mechanical alignment?
Rodney, I think you got to get it right the first time, and really understand the rotational alignment of the femur as well as the tibial component. I still look at the AP axis of the femur. I look at the epicondylar axis, and, with the instrument systems, whether it's 3 degrees, 5 degrees of rotation, but I'm also confirming everything on the femoral side with the anatomic landmarks. And again on the tibial side, looking at the anatomical landmarks, with the implant system I use, the tibial component is anatomically designed so I could get the best coverage, with the right rotation. You're right. Malrotation of one or both of the components, can lead to, mechanical failure of the implant. What I'm seeing more, though, is instability. I see a lot of cases of flexion instability and mid-flexion instability, and many times it's due to malposition of the femoral component. And that's something I address. Just to get back to the whole issue of kinematic alignment that Steve probably spoke about in his alignment, he'll accept some internal rotation of the femoral component, and I'm just very, very concerned about that, and
not only accept it but put it there on purpose.
Absolutely.
He talks about externally rotating the femoral component as a bad idea, and pretty much said exactly that when we talked to him.
Yeah, and I think internally rotating is a worse idea. And that really the femoral component should be in line with the trochlear and getting the right, balance of the flexion space. And the problem is they're internally rotating it throws off your patellofemoral kinematics. And there's been studies that have shown that, it's contrary to what Steve is professing. Internal rotation of the femoral component is not a good idea. It's not a good idea. It leads to flexion instability. It leads to even stiffness. Kelly Vince reported on internal rotation of the femoral component with stiffness, but it also leads to abnormalities in the patellofemoral kinematic. So, I mean, there's so many things going against it that I would just shy away from even considering that.
Well, any final thoughts? We've talked about all the questions that Scott and I wanted to ask tonight, and I think I just wanted to, as a kind of a wrap up, what are the take home messages that you would tell people as they are reading things about kinematic alignment, as they're going to meetings and hearing people talk about it, trying to think about whether they want to implement it themselves? What are your take home points for those surgeons that are trying to put all this together?
I think what's important, for your viewers and your listeners is that mechanical alignment is not a mortal sin. I think there are a lot of challenges to the tenets of mechanical alignment right now. I have an editorial coming out in the Journal of Arthroplasty on this in an upcoming issue with Mike Mont. And my feeling is that be open-minded, but don't throw away mechanical alignment as a very sound principle in doing your total knee replacement. The most important thing is, as I've mentioned earlier, is getting a well-balanced knee that's stable with good range of motion. The whole concept of, personalized alignment, kinematic alignment, needs to be further investigated. We need to look at more long-term studies and decide what are the parameters, what are our guide rails if we want to deviate, from the mechanical alignment. And I think that remembering the basic principles of mechanical alignment, that you do need to do some soft tissue releases. Don't be fearful of releasing the soft tissues, following proper technique, and you should have a very predictable and durable outcome with your total knee replacement.
Great stuff. Well, thanks, Dr. Scuderi, again for coming on and on our show and taking some time for us. We really appreciate this, and that's something some of these concepts we want to hit in the future. We may ask your perspective again. So thank you for doing this. Really enjoyed catching up with you and hearing your thoughts on things.
No, happy to do it, Rodney. Anytime. I always enjoy sitting back and talking about things like this. It's good to reflect back on a lot of the basic principles John Issel taught both of us, and carry on with that.
As always, if you want to get a hold of us, you can hit us up on our social media accounts, Twitter and Instagram at the SKC Podcast. You can visit our SKC Podcast YouTube and Facebook pages, or email us at the SKC Podcast at gmail.com. And we will see you guys next week.